This meeting is being recorded.
It has been an insightful series so far, and we truly appreciate all the participation which we are getting from the attendees. Today's first session is on approach to infective endocarditis. This topic remains clinically challenging, yet critically important. Infective endocarditis currently is no longer a rare disease that we have seen in textbooks, but it's evolving. With increasing invasive procedures, prosthetic valves, cardiac devices, and healthcare-associated infections, the landscape has increased from what we used to see during our earlier days. Still, the diagnosis remains difficult, mainly because the presentations are subtle, and often misdiagnosis can lead to serious morbidity and mortality. So, in current era where antimicrobial resistance is rising, timely recognition of this entity, appropriate antimicrobial choice, and multidisciplinary management are essential skills for every physician. Okay. So it's now my privilege to introduce our speaker on this topic, Mr. Balavinoth Sir, who is a consultant in infectious disease at Kuppuswamy Naidu Memorial Hospital at Coimbatore. He brings his extensive expertise from training in MBBS from Madurai Medical College, MD from KMC Manipal, and a fellow FNB in infectious disease from Apollo Hospitals, Chennai. He is interested and an expert in critical care infections, tropical diseases, transplant and device-related infections, and contributed significantly through his peer-reviewed publications. We are delighted to have Sir with us today, and we look forward to gain practical clarity and structured reasoning on how to evaluate, approach, and manage a suspected case of infective endocarditis. With that, please join me in welcoming Dr. Balavinoth Sir for today's session. Over to you, sir.
Bala, please unmute yourself.
Am I audible and visible, madam?
Yes.
Yes, madam.
Yes.
Okay. Hope my slides are also visible in the slide show mode, right?
Yes, yes.
Yes, madam. Good evening, all. First of all, thanks for the kind introduction, and it's my privilege to be a part of this session. And as an alumni of Manipal, it's really a honor to be sharing this space with you all. And thanks to the entire infectious disease team of Manipal, and special thanks to Dr. Kavita madam who invited me for this session. So without wasting much time, I'll go into the topic proper. And I've been given this topic, approach to infective endocarditis. So I will start with the what are the global guidelines which have been there since 1970s till date for infective endocarditis. Most of the guidelines have come from the American Heart Association initially, and then later we had this. It started in late 1970s, and it evolved through years. Now, recently, European Society of Cardiology 2009, and then the Duke's criteria came into the picture in 1994. It was updated in 2000, and then the current major guideline which we follow right now is the European Society of Cardiology guideline, which has been updated in 2023. The flow of my talk would mostly involve ESC guidelines 2015 and its comparison and updates with regards to the 2023 guidelines. So, first, to define endocarditis, it is the infection of the endocardial surface of the heart. Usually, it has got a mass of platelets, fibrin, and microorganisms with scant inflammatory cells, which can involve either a native valve or any cardiac device, whether it could be a prosthetic valve or other implanted cardiac devices. Usually, it occurs in the low pressure side of a lesion. Actually, for example, a regurgitant lesion on the low pressure side, it occurs. So, and so only we expect endocarditis more in the regurgitant lesions. And also we find this in ventricular septal defects where on the low pressure side actually due to aberrant jets of blood which damages the heart mural endocardium. So if you look at the incidence, it is going to be somewhere 15 cases per 1 lakh per population as per US criteria recently. But with regards to India, there are no major multi-center studies so that we don't have a good surveillance data. And the incidence is increasing due to aging population and lot of cardiac procedures. We have got advanced cardiac procedures with lot of devices implanted, which increases the risk of infection. On one hand, our patient gets good quality of life for the cardiac problems, but on the other hand, they are at risk for infective endocarditis. That should be kept in mind. So there is a shift from community acquired endocarditis to healthcare associated infections because of this modern techniques. So coming to the pathogenesis, always we need a cardiac valvular lesion or some kind of shunt lesion in the heart where there is an aberrant jet which damages the mural endocardium, leading to something non-bacterial thrombotic endocarditis, that is NBTE. When you have a nidus like this, when there is a focus of infection, for example, like when there is a mucosal breach in the dental mucosa, or if there is skin lesions, then this transient bacteremia which happens with everyone with day-to-day brushing or some scratch in the skin, which would not otherwise cause problem in a normal person, when there is a NBTE due to a valvular issue, the bacteremia seeds that non-infected vegetation and proliferates, causes fibrin deposition and leads to platelet aggregation and leads to a mature vegetation manifesting as a full-blown IE as visible in this diagram. So what are the risk factors? It could be cardiac or non-cardiac. So cardiac risk factors would be either a previous endocarditis, a valvular heart disease, a metal device inside the heart like a prosthetic valve, or some kind of implantable electronic device, or it could be even a previous congenital heart disease. Non-cardiac risk factors could be like a prolonged central line which is there in situ, like a dialysis catheter. People who keep injecting drugs, the organism can go from the skin surface to the endocardium, and prolonged immunosuppression, recent dental surgical procedures, long-term hospitalization and hemodialysis, as I already stated. So what are the ways you can classify endocarditis? It can be classified in multiple ways. It could be based on few other, multiple factors. For example, it can be due by the temporal evolution of the disease per se. It can be acute endocarditis, which is which has a rapid onset and a progression which is very rapid, which can be fatal if untreated, which happens in Staph aureus pneumococci, or recently Staph lugdunensis, which is a coagulase negative staph which behaves exactly like MRSA or Staph aureus. Or it could be a subacute IE where it has a very slow indolent course presenting like a typical PO over months or weeks actually, which happens with the typical viridans group endocarditis or viridans group streptococci has a group, or the slow growing pathogens like Bartonella, Coxiella, etc. The other way to classify endocarditis is based on the site of infection. For example, whether it occurs in native valve or a prosthetic valve or a cardiac implantable electronic device. So with regards to prosthetic valve, it is more common in bioprosthetic valves, and the risk is more in the first year after surgery. Coming to the classification based on the cause of infection, it can be bacterial or fungal, or it can even be classified based on predisposing factors like injection drug abuse or congenital heart disease. And in India, rheumatic heart disease could be the most common cause in India or any other developing countries. So coming to the microbiology, most of the endocarditis is due to gram-positive, and the Staph aureus tops the list as expected. And surprisingly, 14% of the endocarditis can be culture negative, and the series extends up to 30% in few other studies. And you can get gram-negative endocarditis very rarely 3% or fungal in 2%. So if you look at the overall picture of these pathogens, you can see that native valve endocarditis most commonly is predominant by the viridans group streptococci. And you can see that again, the streptococci, viridans group streptococci can dominate the prosthetic valve endocarditis in a very late scenario, that is after 12 months. And if you look at Staph aureus, it is there everywhere. Yeah, whether it is community acquired, healthcare acquired, prosthetic valve, everywhere Staph aureus tops the list. And with regards to Candida endocarditis, it is more common in the prosthetic valve setting, especially after 2 months after surgery, up to 1 year is when the Candida endocarditis is more common. So to summarize, overall, Staph aureus endocarditis is common. It arises from the skin. People with multiple boils, Staph aureus colonizers are more prone for it if they have a structural cardiac lesion. Viridans group from the oral mucosa. Dental hygiene is important. Hazard group is from the upper respiratory mucosa. GI tract, especially colonic polyp tumors, leads to Strep galloliticus or bovis related endocarditis. GU tract, anybody with recurrent enterococcal UTI are more prone for enterococcal endocarditis. With regards to prosthetic valve, for the first 2 months, it is a very rapid virulent form of endocarditis where gram negatives also come into picture because it's most often hospital acquired. So again, Staph aureus, fungi and Coriolis negative Staph also predominate the picture. On the other hand, if it is going to be more than 12 months, it is similar to native valve endocarditis with viridans group predominating the picture along with Staph. And with regards to cardiac devices, it is more often with Staph and cons. And people who inject drugs, as expected, skin organism like Staph predominates, the Staph aureus predominates the picture, along with Pseudomonas and sometimes Candida. Culture negative, most often it is due to prior antibiotics, and we should always keep this slow-growing pathogens like Coxiella, Brucella, even Hasek and Whipple's disease in mind.
Bala,
So,
can you just at the bottom of the slide, there is a option to hide the sharing your screen and audio. I mean, in that you can select the side. Yeah.
hide. Okay.
Yes.
Thank you.
Yeah.
Is it okay, madam? Now, is it
Yes.
fine?
Yes.
Yeah.
Continue.
Okay, madam. So, coming to the clinical features of endocarditis, as expected, most of the people present like PUO. So, fever is the most common symptom, and chills, sweats, myalgia, arthralgia is very common. Back pain is a very common symptom with people with endocarditis, and if you auscultate them, they would have a cardiac murmur. A new murmur is indicated in the major criteria for endocarditis. Or you can have the sequelae of endocarditis like a digital infarct due to arterial emboli, the peripheral manifestations like Janvey lesions, Osler's nodes, which are painful in the finger pulp, nodular lesions can be there, or it could be skin petechiae. And if, coming to the investigations, anemia is a very common symptom. Leukocytosis might be there, microscopic hematuria might be there, and ESR, which is more than 100, is very predictive of IE in a PUO setup. And there could be circulating immune complexes, non-specific rheumatoid factor positivity, etc. So paravalvular abscesses, if it is going to be there, it is going to cause conduction blocks. Patient can come with syncope. Rarely the coronary emboli can happen, which leads to myocardial infarction. And whenever a patient comes with the injection drug abuse, he can have a right-sided endocarditis leading to septic pulmonary emboli also. So this is a few pictures where showing Janvey lesions and digital infarcts. Coming to the my first case, a 42-year-old male with no significant past history, a non-diabetic, non-IV drug abuser, recent dental extraction for dental caries 3 weeks back, comes to us with 2 weeks fever with fatigue, night sweats, and weight loss. He had occasional chills, and he had fever and a new diastolic murmur at the aortic area, signifying aortic regurgitation. There was mild splenomegaly. There were no peripheral signs of IE. Investigations showed leukocytosis and normochromic normocytic anemia, elevated ESR CRP, and blood cultures were positive for strep viridans with a MIC of 0.06. Transthoracic echo was normal. TEE showed a 3 mm vegetation in the aortic valve. There were no complications. So coming to the diagnostic criteria. So the diagnostic criteria is based on this Duke's criteria, which is a very old criteria, which was initially modified in 2000, and we have this 2023 International Society proposed criteria, which is the current one. There are significant modification compared to the old to the new one. Coming to the major criteria, first thing is positive blood culture. Initially, it reinforced on this typical organisms which causes infective endocarditis, like viridans group, staph aureus, etc. And they were more particular about the persistent positivity of the culture. They gave guidelines like blood cultures drawn 12 hours apart. All three or majority of 4 blood cultures, with the first and drawn, last drawn at least 1 hour apart, should be positive for typical organisms. These were the guidelines initially. But now the current major criteria again gives a list of pathogen for typical endocarditis in a native valve setting, as well as in the prosthetic valve setting, which involves most of the skin bugs like Corynebacterium, Cons, Pseudomonas, and even non-tuberculous mycobacteria. And now they are not reinforcing on separate venipuncture sites, which was reinforced in the previous criteria. So they are just saying that if you have a typical bug for endocarditis, at least 2 or more separate blood cultures should be positive. If it is going to be an atypical organism, it should be 3 or more should be positive. Though it is recommended that they need separate venipuncture sites, the duration, the spacing have not been given importance in this current criteria. And coming to the the new criteria, it reinforces more on the PCR for Coxiella, Bartonella, Trifurima, Whipple in blood compared to the previous criteria. PCR is included, and if you look at the indirect immunofluorescence assay, has been newly included. Coming to the echocardiographic features in the major criteria, the initial criteria supported only the cardiac structures and the oscillating vegetation in the cardiac structures or the implanted material. Now the current criteria has given more insight into it, including not only echo features, it has included FDG PET and CT angiogram, CT iotogram into picture to improve the sensitivity. That is a dramatic shift in the imaging criteria compared to the previous criteria. And if you look at the another newly included criteria in the major criteria, the surgical criteria has also been included. Visible inspection of the valve is one of the major criteria according to the newer guidelines. So there is dramatic shift in terms of typical pathogens for NVE and PVE, and the reinforcement on separate venipuncture sites have gone down. And along with echocardiography, CT iotogram and PET CT had been given importance, especially if it is done over 3 months after the cardiac surgery, and especially for prosthetic valve, and surgical criteria had been included. Coming to minor criteria, it is almost the same with few additions. Predisposing conditions, fever, vascular phenomena, immunological phenomena like Roth spots, microbiological evidence, with some PCR being included into the microbiological evidence, which doesn't include into the major criteria. And also imaging criteria has been incorporated into the minor criteria, with PET CT being done after 3 months, less than 3 months after a cardiac surgery. Major criteria is more than 3 months. Here it is less than 3 months. It is done especially to find metastatic complications, not only cardiac features. It includes whenever a PET is done to find out metastatic complications, it is included into the minor criteria. And also physical examination criteria has been included into the minor criteria, with new valvular regurgitation or auscultation has been given importance into the minor criteria. Coming to how to diagnose, definitive could be due to either pathological criteria or a clinical criteria. So pathological criteria is nothing but inspecting the valve with the culture and histology after surgery. In the previous guideline, it incorporated only the valve, but the current guidelines incorporates all the devices, including the electronic devices, arterial embolus, etc. So there is no major change. And if at all, with regards to clinical criteria, if you have 2 major or 1 major, 3 minor and 5 minor criteria, it is going to be a definitive endocarditis, which we all know. So what are the why is this new criteria proposed? Because the previous criteria, the older one, had a lower sensitivity for PV and cardiac device associated endocarditis, and lot of definitive endocarditis were missed and were categorized as possible endocarditis. So with the evolution of imaging and diagnostics like cardiac CT, PET, etc., these has to come into the guidelines, and that is what has happened in 2023. And so as we have got more diagnostics, you see this right-sided table, this 2023 criteria has got a very good sensitivity compared to the previous one, but with the expense of specificity, because we find too much which may not be specific, which may not, with all this PET and all, it will over-detect findings, so the specificity gets lower. So coming to the case, as we have gone through the criteria, we have now found out that this is a definitive case of native valve endocarditis with 2 major criteria like positive blood cultures and echocardiac evidence of vegetation. So the management was ceftriaxone for 4 weeks, as it's a low MIC situation, and no surgical intervention because there were no complications. The patient got well, better, completed 4 weeks of antibiotics, and his follow-up TEE showed vegetation which resolved, and he was advised follow-up and prophylaxis, antibiotic prophylaxis for later procedures, if any, especially with regards to dental hygiene. So what about blood culture and empirical therapy in a suspected subacute IE? Always remember general principles. 3 sets has to be sent in any suspected IE, different venipuncture sites, though not reinforced. If at all negative in the first 72 hours, always send additional sets. Empirical therapy only if the patient is unstable, septic, needing emergency surgery. Otherwise, if it is a stable patient presenting like a PUO, don't start empirical antibiotics. Reculture, evaluate for other pathogens, serology. Most of the people have been exposed to antibiotics in the past 2 weeks to cause culture negativity. So in a stable patient, don't be in a hurry to start antibiotics, because if you lose the pathogen, it is going to be a mess. We will not be able to treat. So always culture. And if cultures are negative, look for non-culturable organisms, PCRs, metagenomics, and then think about non-infective causes like SLE, marantic endocarditis due to malignancy, etc., by doing advanced imaging like PET or ANA, etc., to find out the cause. So whenever you have a monomicrobial bacteremia due to one of these organisms like Staph aureus or Enterococcus or a Viridans group Streptococcus, there are a few scores which will help us to say if this patient needs a IE evaluation by a echo. For example, Staph aureus, this is a Vista criteria. If the score is more than or equal to 3, or de novo criteria for Enterococcus, if the score is more than or equal to 3, or a Handoff criteria for Viridans group, if the score is more than or equal to 3, then always evaluate for IE. So coming to the imaging, we all know that this FDG PET and CT and iotography have been given importance as much as similar as echo, and but nothing replaces the echo. TTE should be done for all. Though it is a very sensitive test, it lags behind TE in sensitivity. See, TE's sensitivity is somewhere around 90%, but TTE can be 70 to 80. It misses small vegetation less than 2 millimeter, but it's poor, and it's poor for prosthetic valves and devices. All these are the advantages with TE, where the sensitivity is higher. The prosthetic valve and intracardiac devices and complications, it inspects better. 3D evaluation helps more. And whenever the suspicion remains and initially there is a negative TE, you have to repeat a TE in the next 1 week or so. And coming to CT coronary, CT iotogram, it is a superior test for paravalvular abscess. And PET again is a very good test for devices like PVE, any aortic graft, LVAD, or an implantable electronic device. And also it gives us clue about the metastatic complication when we do a whole body PET, especially done after 3 months. Because less than 3 months, there could be surgical changes which might light up in the PET. So we have to be very careful interpreting. And so whenever IE is suspected, if it is a low suspicion, TTE should be done. So if the low suspicion persists, then look for another source if the TTE is negative. As and when the suspicion increases, when there is a negative TTE, always do a TE and try to find out if you have a positivity. Go ahead with treatment. Even with the TTE positivity, that is even if the TTE is positive, if you have high risk echo features and if you are thinking about complications, always try to do a TE. On the other hand, whenever you are inspecting a prosthetic valve, always try to do a TE. Even if you look at TTE vegetation, prosthetic valve should be evaluated with TE in all patients. And if there is a high degree of suspicion with the initial TE being negative, always repeat your PET in 5 to 7 days. And at the end of treatment, a repeat TE or TTE should be done to have a baseline to after treatment to if at all if the patient comes with fever later to see if there is a relapse, increasing size of vegetation should be always be looked at. So at the end of 4 to 6 weeks, when you finish treatment, always try to do an echo to find a baseline and record it. Whenever there is a right-sided endocarditis, TT is enough is what the guidelines say. TE may not be necessary. And transesophageal echo is a must. If at all you are trying to switch the patient to a oral therapy, which has been incorporated into this current guidelines. And whenever the patient is being operated, an intraoperative echocardiogram is a must. That is what all these guidelines say. And this is what the ESC guidelines say, proposed algorithm for both native and prosthetic valve, which I have already told you. And coming to the case 2, it is a 56-year-old male, a type 2 diabetic with chronic skin ulcers, prior hospitalization with cellulitis. He comes with a very high-grade fever, and on examination, he has got a systolic murmur at the apex. He is confused neurologically, but no focal neurological deficit. He has got a healing ulcer in the lower limbs and has got a left loin tenderness. And his blood cultures grew, MRSA in all 4 sets, and he has got a very high count, CRP being high, ESR being high, mild renal dysfunction. MRI shows small embolic infarcts in the right parietal lobe, and urine analysis shows pyuria and microscopic hematuria. So it is a MRSA bacteremia, high level MRSA bacteremia. So is there a IE? And it is TTE. Sorry, I forgot to mention. It was normal. It didn't show any vegetation, but the TE showed a typical vegetation in the mitral valve because he had loin tenderness, etc. A PET CT was done, which showed a septic embolic features with minimal abscess-like features in the left kidney. So, because it's MRSA endocarditis, a surgical consult was obtained and they deferred again surgery because the patient has no complications. So, the patient went ahead with treatment with vancomycin, which was given for 6 weeks, and he improved with that with a repeat PET CT showing a resolved FDG uptake and the echo showing the shrinkage of size of vegetation. Patient neurologically also improved. And he was sent home at 6 weeks advising MRSA decolonization and dental prophylaxis. And this case shows the importance of PET CT not only in finding the cardiac features of endocarditis, it has also been of help in finding the metastatic foci, especially in the kidney, and it will help in bone, brain abscesses also could be found with this therapy, with this modality which is evolved now. So coming to the next case, it is a female patient with prosthetic valve in the aorta, and which was done 18 months back, comes to the OPD department without any symptom actually when she presented. Actually, she gave a history of fever almost a week back, which lasted for a week. And for the past 1 week, she had been afebrile and she was treated like a UTA elsewhere with antibiotics. But surprisingly, in an asymptomatic state, she had a very high counts and high CRP, but no pyuria. So this alerted us something is happening. She has got a prosthetic valve. So we did the echo straight, but it was normal. There was no other clinical signs, but we erred on the side of doing a blood culture, but she was not started on any antibiotics. She was sent home. But surprisingly, all three sets grew stenotrophomonas. So the patient remained, on the follow-up also, she remained afebrile, but we couldn't find out the source. So we went for a TE, it showed no vegetations. Repeat blood cultures were sent, and because we were not clear about the source, a PET was done. And it showed we were under cardiac protocol was planned. In the meantime, the patient was started because we couldn't ignore this 3 sets culture positivity in the setting of prosthetic valve. So we started minocycline and levofloxacin, which were the only drugs sensitive for this stenotrophomonas. But PET showed a cardiac vegetation in the prosthetic aortic valve, which can be seen in the right side picture. And you can see that the repeat cultures also grew stenotrophomonas. So prosthetic valve, the diagnosis very clear about prosthetic valve endocarditis due to stenotrophomonas in this case. And we continue the same antibiotics for 6 weeks. She's still on treatment. She's under our follow-up. The cardiothoracic surgeons were asked to review, but they said the patient is stable without complications, no surgery for now. They told we'll follow up. So we are planning for a PET CT at the end of 6 weeks, which will probably complete in the next 2 weeks. So this is one case where PET highlights the importance of PET CT in diagnosing the endocarditis, especially prosthetic valve endocarditis, which was missed in the TE. So it will be very useful if it is done over 3 months, where the confounding factors post-surgery can be avoided if it is done over 3 months after surgery. So what are the principles of antimicrobial therapy in IE? So IE, it is there in the vasculature. So it's a load of infection sitting there. So you need a drug which is bactericidal, and you have to give it for prolonged duration. And the drug should have high serum levels, and it should diffuse into the vegetations. So whenever thinking about empirical treatment, think about diagnosis. In a stable patient, always try to diagnose rather than starting empirical therapy, which is the case in a patient with complication where urgent infection control like surgery is needed. Other factors would involve the metastatic complication, whether the meninges bone is involved, look into the side effects, allergies of the drugs and interactions. And the duration is always measured from the first negative blood culture. So it is longer for PVE 6 weeks, and for NVE it is going to be 4 weeks. And adjust the drug dosage for toxicity and organ dysfunction also. So coming to the each and every aspects of endocarditis treatment with regards to the pathogen, whenever you look for strep endocarditis, look at the penicillin MIC. And I'm not going into each and every aspect of the treatment, which is more elaborated. It will be out of the scope of this talk. So I'll just tell the general principles. Coming to enterococci, always look into whether it is a penicillin sensitive or resistant. That has to be looked into. Coming to if it is VRE, always like the drug of choice would be daptomycin combined with the beta-lactam like ampicillin, fosfomycin or ceftriaxone. And if it is going to be Staph aureus, if it is methicillin sensitive, we are going to use like substituted penicillins like oxacillin, nafcillin or flucloxacillin or cefazolin. If it is MRSA, the drugs of choice would be vancomycin or a daptomycin. Whenever there is a prosthetic valve scenario, especially with regards to Staph aureus endocarditis, always add Genta and rifampin actually, and the duration would be 6 weeks. And hazard group of organisms, then the drug of choice would be ceftriaxone, which is given only for 4 weeks in a native valve and 6 weeks in a prosthetic valve. So in a non-hazard group gram-negative endocarditis, for example, this happens more commonly. It could be E. coli, Pseudomonas, Klebsiella, etc. And our case like Stenotrophomonas. More commonly occurs in prosthetic valve. It has got a high mortality morbidity, and always needs surgery along with prolonged therapy up to 6 weeks. Medical therapy alone has high failure rate. And the drug studied with regards to this is typically meropenem and cefepime, not other drugs. Always they are recommending combined therapy along with the aminoglycoside like tobramycin. Sometimes fluoroquinolones are also recommended. And the susceptibility guides our therapy selection. And These are the general principles. I didn't go into details. I've gone just into the general principles. Streptococci, always check penicillin MIC. As the MIC creeps, add gentamicin. Coming to Staph aureus, whether it is native or prosthetic valve, usually 6 weeks of treatment is recommended, actually, even in native valve setting. And if it is going to be prosthetic valve, along with the baseline therapy like MSSA cefazolin or MRSA vancomycin, add rifampin and gentamicin, because rifampin is a biofilm active agent. And when there is a MIC creep with vancomycin, always consider daptomycin. In Indian scenario, we have even teicoplanin, high dose teicoplanin can be used. With regards to enterococci, whether it is ampicillin sensitive or resistant, if it is ampy sensitive, you can add ceftriaxone to ampicillin instead of aminoglycoside to avoid nephrotoxicity. Double beta-lactam, though ceftriaxone is not drug of choice for enterococci, will increase local levels of ampicillin and will potentiate its action. It is going to be ampicillin resistant. Vanco plus gentamicin is the drug of choice. All PVEs would need gentamicin for its synergistic action. If it is going to be a non-hazard gram-negative, 6 weeks of therapy along with surgery is a must. So the general rule is native valve, except for Staph aureus, treat for 4 weeks, and prosthetic valve all 6 weeks, most often with gentamicin. What with regards to culture negative endocarditis? Almost 30% can be culture negative. Predominant reason being prior antibiotic exposure, commonly due to these bugs like MSSA, strep, or enterococci, which are simply killed by your routine augmentin given in the OPD setup. Very rarely it could be due to the non-culturable organisms like Coxiella, Bartonella, or sometimes fungi, or non-bacterial thrombotic endocarditis, as I previously told, malignancy or SLE. So always try to do multiple cultures. If that is negative, look for PCRs and serology for fastidious pathogens. The imaging and diagnostic criteria are similar, and always consider prior antibiotic exposure if anybody is culture negative. So these are the workup principles for all these non-culturable fastidious organisms. I'm not going into the details. Most often it involves serologies, cultures, both of the valves and blood, as well as metagenomics and PCR, which are the newer additions in this particular criteria. So whenever there is a concern about culture negative endocarditis, they are the AHA update in 2025 says that you have to collect blood and keep it aside for future metagenomics, actually, and always repeat cultures are warranted after 3 days, even if the previous culture is negative. And whenever you think of fastidious organisms, the lab should be alerted with regards to holding the cultures up to 21 days. Though the conventional, the current automated systems can detect most of the organisms by 5 days, still this is a recommended practice to hold cultures, especially in Indian scenario, Brucella, and again Bartonella, Q fever, etc. Should be held for a longer period, up to 21 days is what the current AHA update in 2025 recommends. So what are the empirical regimens, which should not be the rule? Whenever you have a sick patient where you are pushed to start a therapy, there is a difference in the empirical therapy regimens with regards to US and Europe. In the US, for native valve endocarditis, they simply cover with ceftriaxone with vancomycin. In the European regions, they don't include vancomycin, but they cover things for enterococci with ampicillin with ceftriaxone, along with the MSSA cover flucloxacin, along with gentamicin. If it is going to be a PVE, the US guidelines are very clear. In the first 2 months, they are at risk for MRSA, so vanco, rifampicin, and gentamicin has to be given, along with a gram-negative cover like cefepime. And if it is going to be late, it reflects something like a native valve endocarditis after 12 months of the valve implantation. So again, the regimen would be vanco with ceftriaxone, which will cover the viridans and Staph aureus, actually. The European guidelines, again, if it is going to be a prosthetic valve, they are incorporating either vanco or dapto along with gentamicin with rifampin for a biofilm activity. So in a stable patient, please don't start empirical therapy, wait for the workup. And always how to prevent this prosthetic, blood culture negative endocarditis. All these operated patients, when they go home, should never go to for simple illnesses, go somewhere and start antibiotics. Instruct them at discharge. Any high-grade fever, unusual or prolonged fever, don't start antibiotics. Come to us, do cultures, and then we will decide to start antibiotics. That should be the advice given to them. And coming to fungal endocarditis, commonly it is due to Candida or Aspergillus, especially in a prosthetic valve setting. Very high mortality, 50%. Most often will require a valve surgery along with prolonged antifungal therapy, which would be needed for even for years as suppressive therapy orally. And avoid empirical therapy, but in 6 scenarios where high suspicion of fungus is there, after sending your biomarkers, you may choose to start, but not the rule. And specifically going into Candida endocarditis, again, all Candida groups can cause endocarditis, especially in a prosthetic valve setting and injection drug abuses. Drugs of choice would be high-dose echinocandins. The alternative would be liposomal lampho with flucytosine for synergistic action. Surgical management, valve replacement is strongly recommended, especially for prosthetic valve endocarditis, and the duration is 6 weeks. If you are not able to do a valve replacement, then you need a very long suppressive therapy with fluconazole if sensitive, even lifelong. That is what is recommended. With regards to Aspergillus, again, it is a culture negative situation, large vegetation, it can embolize easily, and commonly surgical replacement of the valve is recommended, and the drug of choice would be oriconazole. Even isoconazole and ampho had been used for it, but most often requires after surgery and 6 weeks of oriconazole, lifelong suppressive therapy with oriconazole. Mortality even with surgery is 70%, but without surgery it approaches 100%. So device-related, implantable electronic device-related endocarditis is somewhere kind of similar to prosthetic valve endocarditis. You need treatment for 4 to 6 weeks, and the device should come out. If it is going to be a pocket infection alone, you can even treat with oral antibiotics and drain the pocket out, relieve the pus, and you can treat it for 10 to 14 days. Most oftenly caused by Staph aureus or cons. Single culture positivity due to uncommon organisms like gram-negative streptococci in this scenario may not be CIED related, and removal is not warranted unless always the patient relapses with the same organisms. And after removal, generally the new device implantation can occur after culture negativity after 2 weeks. Then the device removal, reculture if it is negative, and if there is no vegetation in the previous device, you'll have to wait for 2 weeks for reimplantation of the device. And commonly we are doing TAVI, cutaneous aortic valve implantation, which is commonly done, which behaves exactly like prosthetic valve endocarditis. The same principles apply. And the newer guidelines insist on OPAT, that is outpatient parenteral antimicrobial therapy in IE. Definitely, it can be considered, especially in a patient who is very stable, non-bacteremic, no complications, all source controlled, and if he has a reliable IV access, if he can be monitored at home, a good antibiotic which is very stable in solution is available, then it can be done at home with a good team to monitor. Don't compromise on the regimen because he is going home. But this, if at all you have a suitable patient with a suitable drug, it is a very good way to reduce the hospital stay and improve the quality of life. Coming to the newly evolved regimen based on this NEGM trial, POET trial published in 2019, they evaluated whether we can do partial oral therapy after initial intensive IV therapy after some 10 days compared with the complete IV therapy for 6 weeks. They found that whenever the some 400 participants were involved in this study, and whenever the bug is streptococci, enterococci, or MSSA, this was applicable, and it met the non-inferiority of compared to the full IV therapy. That is, the mortality rate was 6.5% versus full IV therapy, it was 7.5%, almost equal at the follow-up of 6 months actually. But the criteria satisfied should be the patient should have been stable, and at least 10 days of IV therapy should have gone in, and the patient should be stable. There should not be MRSA, and the cultures could have got sterile. And after surgery, at least 7 days you should develop get IV therapy, and then you can switch to oral. Always do a TEE before switching to oral. This has not been given much weightage in the criteria, though it has been recommended. It is only in the class 2B recommendation with regards to this. This is what the ESC guidelines tells regarding both OPAT and POET. Patients should be stable. With regards to oral therapy switch, CRP should be less than 25. Patient should be afebrile for 2 days, and the leukocytosis should have been resolved, and at least 7 days therapy should have gone in. Then only you should decide on giving partial oral therapy. And with regards to oral therapy, they say at least 2 drugs with the good biofilm activity and synergistic activity and good tissue penetration should be chosen. That is what they say, and TE is a must before switching. So coming to my last case, this is a 52-year-old female, diabetic, and with a permanent pacemaker and prosthetic valve in the mitral area, implanted 2 years back for RHD and 6 sinus syndrome respectively. And she's on long-term oral anticoagulants. She had a fever like 1 month back, lasted for a week with diarrhea, for which she took intermittent antibiotic. And now she again presents with fever after a 2 weeks interval with high-grade fever, chills, and she was febrile, dehydrated, was pale, had a systolic murmur in the mitral area, and she had anemia, high counts, and ESR and CRP was high, and procal was high. Blood culture grew gram-negative bacilli in all 6 bottles because she had a long fever. IE was a suspicion with the devices inside the heart, and blood culture was done under IE protocol. All 3 cells grew. Salmonella typhi, which was confirmed later, and we were able to find out a vegetation in the transthoracic echo. There was no lead vegetation. It was only in the prosthetic valve, but the transesophageal echo showed the lead vegetation as well as the prosthetic valve vegetation. So it was a lead as well as prosthetic valve endocarditis due to Salmonella typhi. So cardiologist and CT surgeon opinion was sought, and they definitely advised surgery with lead extraction out, but the patient completely denied it. So with available guidelines, as there was not much weightage for ceftriaxone, though it was sensitive with regards to a prosthetic valve setting, we didn't have much data. So meropenem itself was continued for 6 weeks. We didn't have an adjunct fluoroquinolone, which was sensitive. Cotrimoxazole was sensitive, so it was added to the regimen. And after 6 weeks, repeated cultures were sent in the middle in that 6 weeks treatment, which all sterilized. So after 6 weeks, a repeat echo was done, TE was done, which showed a vegetation size which was decreased and shrunk, and it was in fact started calcifying. So we thought the patient remained stable, so we started giving this cotrimoxazole for a year, and after that she was not willing to continue further. So even after stopping 2 months of, after 1 year, cotrimoxazole was stopped, and 2 months after the oral therapy was stopped, still she remained clinically stable. This is one such case where a prosthetic valve lead endocarditis was managed without surgery, but it's still not the recommended way of treating her, as the patient denied surgery, and we wanted to do a PET at last to see if that activity has gone down. She was not willing for that as well. So she has received 1 year of oral suppressive therapy with cotrimoxazole, thankfully without side effects, and doing well till now. So, and this is not a typical case of partial oral therapy as suggested in guidelines. I just wanted to highlight a different case which we went through in the recent past. So whenever there is a antimicrobial therapy is being given for a longer time, whether IV or oral, always look into the pharmacodynamics, kinetics, look into the toxicity. Trough levels had to be done for vancomycin, aminoglycosides, AUC by MIC for vancomycin particularly, and blood cultures had to be repeated in a few till it's sterile, especially with Staph aureus, Candida, etc. And the therapy starts from the day of clearance. Usually, Viridans group clears in 2 days, MSSA 5 days, MRSA takes longer, even up to 1 week. But if there is persistent bacteremia, always look for complications at the local site. Is there a paravalvular abscess, or is there metastatic complication like splenic kidney abscess, which has to be addressed, may need a PET also. Surgical indications, generally it is indicated for any cardiac failure, valve leak, acute valve leak leading to cardiac failure and cardiogenic shock. If the vegetation size is more than 10 millimeter and there is a recent embolus, and if it is going to be more than 30 millimeter where there is high risk for embolus, we'll have to think of surgery. And also prosthetic valve endocarditis always have a upper hand for surgery. Actually, any dehisced valve with the tilting paravalvular leak, always think of surgery. And if it's going to be causing a conduction block, then always think of surgery. And difficult to treat pathogens like Candida, Pseudomonas, resistant gram negatives, always think of surgery. Whether the timing of surgery, if it is going to be a emergent surgery, if it is going to be a shock or a cardiac failure. All other relative scenarios like root abscess with a conduction block, septal perforation, etc., Candida, always urgent surgery where you will have to plan in somewhere within 1 to 2 within a week or so. If it is going to be a stable case but meeting the criteria with a major AR or a valve leak, then you can plan the surgery after 1 week, after the culture clearance and all. So the decision on surgery has to be taken, and the timing is very important in 6 scenarios actually. Whenever the valve is extracted, always try to do a culture from the valve and also histopathology. And nowadays you'll have to do metagenomics and PCR if the culture is going to be negative. And even when the tissue sample is limited, always prioritize to do a molecular testing like PCR, metagenomics over culture, because a lot of times culture can be negative. Culture yield is poor from the explanted valve. But culture has to be done in every other case. But if you have a limited sample, try to give importance for PCR and metagenomics rather than culture. So if at all your patient has a neurological complication, can you do surgery? Yes. If it is going to be a minor ischemic stroke, always early surgery is warranted. But if the patient has got an intracranial hemorrhage, weigh the scenario. The patient has got a meaningful recovery which is expected, think of surgery still. So if it is going to be a major bleed, then wait for 4 weeks. And if it is going to be a non-hemorrhagic major infarct, wait for 3 weeks. But the quality of life is not going to be better with regards to neurology, avoid surgery. And if there is a mycotic aneurysm, address the aneurysm first before doing a cardiac surgery. So stroke is never a contraindication for surgery. If it is a minor ischemic stroke, always surgery improves the outcomes. We can see in this right side graph where stroke with surgery has got a survival rate almost equivalent to a patient with no stroke. So don't defer surgery just for the sake of stroke if it is a mild ischemic stroke. And for a lot of people with surgical indications never get surgery. That is the reason a lot of people without surgery go in for when you do a long-term follow-up at the end of 1 year, they have high mortality. So in indications for surgery, try to do a early surgery after discussion with the multidisciplinary team.
Sir, we are 5 minutes over shooting the time.
Yeah, I'm just wrapping up in 5 minutes.
Okay. Yeah.
So antibiotic therapy after cardiac surgery, generally you do a valve culture. The valve culture is positive. The culture, the duration would extend from the time of surgery another 6 weeks. If it is the valve culture is going to be negative, then the entire duration of 6 weeks should be covered. Even the pre-op antibiotic course has to be counted. And always looking for extra cardiac complications like splenic abscess should be drained or a splenectomy should be done. For mycotic aneurysms, monitor if it is a small aneurysm with angiography. If it expands or leaks, then do a surgical treatment or an endovascular treatment. Extracerebral aneurysm, surgery is a must in most of this if it is going to be a symptomatic aneurysm. And antithrombotic therapy unnecessarily should not be withheld unless otherwise you have a large embolic stroke or a big ICH or a mycotic aneurysm. Routine, if you don't have these contraindications for prosthetic valve, AF patients, DVT, always continue the anticoagulation for throughout the period. And if it's going to be a major ischemic stroke or an intracerebral hemorrhage, try to reverse the anticoagulation. So the better therapies in this scenario, instead of OACs, always prefer LMWH or your UFH because it can be reversed in a major stroke scenario. And outcome, most of the people with the available diagnostics and treatment survive up to 85% in globally. Actually, in Indian scenario, also the survival is similar, but we have a lot of MDR bugs here that should be kept into mind. With regards to step viridans, the survival is better. The staph, it is almost like 50 to 70% compared to strep, which is 90%. With prosthetic valve, early prosthetic valve endocarditis, the mortality rate is higher, up to 50%. That should be kept in mind. So, whenever a patient goes back home after endocarditis, always insist on dental hygiene. He should brush the teeth twice a day, and at least high-risk patients should have twice yearly dental examination. Any skin insults had to be seen by the dermatologist. Avoid unnecessary antibiotics. Present to the hospital early for prolonged fever, and blood cultures are a must. This advice should be given. And
Can
whenever
you, Bala, can you go to the conclusion? Because
Yes, I'm just wrapping up. So only for high risk scenarios we'll have to give a antibiotic prophylaxis like prosthetic valve, prior endocarditis, any device in the system, or congenital heart disease which is unrepaired, or valvulopathy after cardiac transplantation. We need standard oral prophylaxis which involves amoxicillin or ampicillin within 1 hour of procedure. Clindamycin had been removed from the recommendation, and for it should involve routine dental extraction is not indication for prophylaxis. It should involve gingival manipulation or periapical region manipulation for prophylaxis. Otherwise, prophylaxis is not recommended. For genitourinary procedures, no prophylaxis is needed. So now this current guidelines insists on long-term follow-up care, especially for prosthetic valve endocarditis, and it insists on patient-centered care and formation of endocarditis team in all hospitals which handles much endocarditis, like most of the cardiac centers. It involves cardiologists, cardiothoracic surgeons, ID specialists, and microbiologists for sure. And comprehensive decision making has to be done by the team. So coming to my conclusion, IE is an enigmatic disease. Remember typical pathogens, use high index of suspicion and scores, and always follow the current new ESC criteria. New typical pathogens had been added. No major emphasis on separate venipuncture sites or timing of blood culture. TTE is a must for all. TE is a test of choice for staph aureus, prosthetic valve, or any device or fungus. Newer modalities like CT, iodogram, and PET should be incorporated, especially for prosthetic valve for metastatic complications. And also rapid molecular diagnostics like PCRs and metagenomics like 16S RNA should be included. IV to oral switch can be considered if the patient is stable, but the evidence is low. Early surgery should be done in indicated cases, and especially shock or pulmonary edema. Look into this device-related endocarditis, which has been incorporated into current guidelines. And every high cardiac volume center should have an endocarditis team, and there should be strong focus on shared decision making and structured follow-up. And more studies, multi-center studies, should come in India to have our own data. Thank you. Sorry for crossing the time limit, but if there are any questions, I would be happy to answer.
Thank you, sir, for your excellent presentation and converting an exhaustive about a 5 to 6 hours topic into 45 minutes. We have a few questions. Because of time constraints, I'll be going through a few ones. So one of the relevant question would be, in culture negative endocarditis, at what point do you feel comfortable narrowing down therapy instead of covering everything with respect to antimicrobial stewardship?
In a culture negative endocarditis situation, like one thing which we can be very clear about is if you have started a MRSA cover and your repeated cultures are coming as negative, and we are quite sure that a patient come from a OPD scenario elsewhere treated with augmentin or something would not have covered MRSA. So it is very rare to have a MRSA being covered by the OPD treatment elsewhere. So if at all, if I have started a MRSA cover in a patient with culture negative endocarditis and my repeated cultures are sterile, I would prefer to stop the MRSA cover. That is one thing, like Vanco or Teicoplanin, which I've already started, I would try to stop. That is one thing which can be done in a culture negative endocarditis situation, and especially if I think that the culture is negative due to a previous antibiotic therapy rather than other causes like fastidious organism. So MRSA cover can typically be stopped if the patient is culture sterile and if you are clear about his previous prescriptions.
And other relevant question is, when would you consider starting empirical antifungal therapy in endocarditis?
Definitely not as a routine, because like when we start treating fungus, we'll reach nowhere if we start treating it and thinking it as fungus. Definitely not as a routine, but very, very rare scenarios. You have a prosthetic valve and your culture is repeatedly sterile. It is a large vegetation. Patient is sick and he has got other risk factors like immunosuppression, and probably has got multiple IV lines in the past. We had Aspergillus and endocarditis a couple of years back, well, for a patient who had tricuspid valve Aspergillus endocarditis, who received IV therapy elsewhere twice, thrice, and he had a skin lesion. And then after that, he developed a prosthetic and something like a long-term IV access in the past. And your culture keeps being negative. All your fastidious organism workup is negative. And if at all you have a positive biomarker without any confounding factor, like a galactomannan or a beta-D-glucan being positive, that is the only scenario in a sick patient I would try to cover prosthetic valve endocarditis with a antifungal. Otherwise, not as a routine. Most of the times, prosthetic valve endocarditis due to fungus is diagnosed during surgery. I mean, fungal endocarditis is diagnosed during surgery when the valve is explanted. Very, very rare scenarios we can do this, but not as a routine.